Well, kia ora everyone, and welcome along to the second of our ACC primary care market events today. Before we kick off, I am just going to go around our team here in ACC with a quick round of introductions. So, ko Chris Ash tōku ingoa. I'm the head of health partnerships at ACC, which means I'm responsible for the commissioning of the $4.5 billion we spend on health services for injured New Zealanders. My background, I'm a general manager and chief operating officer who's worked across hospitals, mental health, community and primary care in both the UK and New Zealand over the last 20 years. I've been with ACC since the end of September. And so I'll pass on to my colleague, Dilke.
Thanks, Chris. Good evening, everyone. It's lovely that you're able to join us for this session. So I'm Dilke Rasaya. I am acting Chief Clinical Officer currently with a great interest and passion in clinical governance, quality and safety. I'm trained at Otago University, med school, medical administration is my background, and I've been at ACC for 10 years now. I will pass on to Pete Watson.
Good day, everyone, and great to join you all tonight. So my name is Pete Watson, originally a paediatrician by training, spent most of my time working in clinical leadership roles at counties and in Health New Zealand. I've recently joined the team here at ACC, providing advice on clinical leadership and clinical governance. Great to be with you tonight. And I am handing over to Stafford.
Kia ora koutou, Stafford Thompson, Manager Health Sector Engagement and Performance at ACC. So I have the privilege to support our allied health, primary care and ambulance portfolios that sit within our scheme entry space. I have a background as a physiotherapist and have had leadership roles in the public health system prior to coming into ACC. It's my pleasure to introduce Marianne Graham.
Kia ora everyone, and thank you for making time for us this evening. Ko Marianne Graham tōku ingoa. I'm ACC's Portfolio Manager for General Practice, Nursing and Dental Services. I've been at ACC for 10 years now. 5 years I've had the privilege of working with this sector, and I have a background in pain management. I'll hand over to Lee. Thanks.
Thanks, Marianne. Kia ora koutou, ko Lee Aston, tōku ingoa. So I'm a portfolio advisor for ACC's General Practice Nursing and Dental Services. I've been with ACC for around 6 years and I have a background in primary care management. Over to you, Cody.
Kia ora koutou. Thanks for joining us this evening. I'm Cody Bedford. I'm the health partner for general practice and physiotherapy at ACC. I've been here for about 6 years in various different roles. I have a background in health science and psychology. I'll pass back to Chris.
Okay, well, thanks, team. And I get the unenviable task just of a bit of housekeeping before we start. So so that we can use our time wisely today, we would ask you to use the Q&A function, which is at the top of your screen, for any questions or feedback you want to submit during our session. An important thing to note is that we don't have a chat function in the webinar. So when you post those messages, they will disappear. But Lee, Marianne and Cody will be working diligently in the background to make sure we answer as many of the questions you've posted as we have time for. If there are any common questions coming through, we may address the theme rather than going to the individual questions. We've also collated the questions that some of you sent through ahead of time, and we will cover those off in our Q&A. Although, of course, all questions are valid, any that don't specifically pertain to the content or the purpose of our market event this evening, we won't cover off during the session, but we will make sure we loop back round on those with the individuals who've raised them. And we may not have time to answer all the questions, but we will collate and respond to any unanswered questions in writing after the event. We'll also email a link to this webinar for anyone who registered to attend, and we can make that link available to others if you have people who'd like to see that material. And look, finally, I'll repeat, we're so grateful to see so many of you present tonight. We hope you're going to enjoy what we've got to say to you this evening and it will inspire you. So yeah, let's kick on in. Could we bring up the agenda? So this is the agenda for what we're looking to cover on this evening's call. And I guess my introduction to this would be that for us, 2025 is about ACC resetting its relationships and the way that we work with our partners in the health sector. Most people I speak to recognise the huge value or taonga that a scheme like ACC is for New Zealanders. But I think we've found ourselves in a position over a number of years where that scheme is probably not doing the very best that it could for injured New Zealanders. And we think that only by engaging more closely with our partners in the clinical sector can we bring about the changes that are needed to keep our scheme sustainable and delivering the maximum that it can for Kiwis' health and care. And we're starting our market events with the engagements with primary care. And that's because we understand the importance of the primary healthcare sector in the whole healthcare equation. And, you know, we thought it's really strategically important we start that conversation with primary and openness. I was certainly interested when I came into ACC 5 months back at the chart that you'll see on the right of your screen there, which, you know, with no detriment or denigration to our allied health colleagues in the allied health sector, it struck me as slightly odd that we spend well over double on the allied health sector that we spend in primary healthcare, primary point of care for people who enter our scheme, and also that real point of continuity in the system. So, you know, personally, I will say as a senior leader in ACC that I think we have underinvested in primary care. And the COPE of this evening is about how we find new and better ways of working with you that solve some of the pressures and challenges that you are under as a sector, but also contribute to a really strong, sustainable ACC scheme that can benefit future generations of New Zealanders. And on that note, I'll pass over to my colleague Marion, who will talk to some of those points in a bit more detail.
Kia ora, thank you, Chris. We felt it was extremely important at the start of this kōrero that we take a few minutes to completely acknowledge and understand the pressures you are under and have been under for a while. There are many factors that contribute to this, such as we know you have a constrained workforce. We know there's increased patient complexity due to an aging population, an increase in chronic conditions, and looking after patients with multiple comorbidities. You're having to take on more and more responsibility due to the drive to keep people out of the hospital setting and managed within the community. We know there's an increased percentage of practices with closed books for new enrolments, and you're reporting high reports of burnout. There's complexity of different funding models, and you're uncertain about your financial sustainability. We also appreciate that this pressure can impact your ability to do what you do best, which is influence the safety and well-being of your patients and wider communities. You are best placed to do this because you have an in-depth understanding of the whole patient. You build therapeutic patient-provider relationships. Your patients trust and respect you. You are the first point of contact for patients within the New Zealand healthcare system and a key gateway to onward referral and pathways of care. You have an amazing focus around health promotion and prevention. And importantly, you provide care through all stages of life and how this continuity of care has been linked to improved health outcomes, people living longer, and can also reduce the overall cost to the wider health system. At ACC, we know that primary care plays a critical role in helping injured people recover. For example, we know that you complete approximately 2 million appointments with injured New Zealanders per year. This means that primary care currently makes up around 60% of the entry into the ACC system. We know that 82% of all medical certificates are completed within the primary care setting, and you complete on average 45,000 medical certificates per month, and 70% of all medical certificates for weekly compensation, which equates to $1.8 billion, are completed within general practice. As we will explore in the next few slides, injured Kiwis are now taking longer to recover than they were 10 years ago. This is putting significant strain on the sustainability of our scheme. To ensure ACC remains available for future generations, we are eager to collaborate more closely with you to find innovative solutions that will make a real difference for you, for us, but most importantly, to ensure injured New Zealanders can have the right supports at the right time to maximise their recovery. So as I've mentioned previously, I've had the pleasure of working with this sector over the last 5 years. Over those years, you've shared with us that you would like us to be more culturally responsive, be easier to work with, make the return to work process less complex to navigate. reduce your overall admin burden, particularly in relation to medical certification and clinical notes requests, and provide more flexibility in how you can deliver services. There is still work underway, but we have responded to some of this feedback, and hopefully you can see on this slide to the right that we haven't initiated some projects. We hope that some of these have made a difference for you, but we're here today because we accept and appreciate there is still opportunities to make things better. Thank you very much. I'll hand over to Stafford.
So our rehabilitation rates and weekly compensation costs for ACC are not where they should be, and have been trending in the wrong direction for several years now. For example, you are now 30% more likely to start weekly compensation if you're an employed New Zealander than you were 10 years ago. This is despite the fact that there has been no increase in the claim volumes over that period of time when we look at on a per population rate within New Zealand. In addition, we now have more than 20,000 New Zealanders who have been on weekly compensation with our scheme for more than a year. And of that, we know there's more than 10,000 patients or clients who have been off work for more than a year with what we would describe or think of clinically as mild to moderate injuries. And we're not clear as to what's stopping these patients or clients recovering. It's really important for ACC to understand this, as it indicates our patients and our clients are not getting what they need to return to work. And we as an organisation need to understand this because it is impacting the sustainability of our scheme as we move forward. I'm just going to hand over now to Peter Watson, who's going to talk in more detail about the clinical aspects of this.
Thanks, Stafford. So just building on what Stafford's been saying, one of the important facts is to understand that ACC used to spend more on assessment and treatment than weekly compensation. But now the reverse is true. So weekly compensation is costing the scheme more than assessment or treatment. If we look at this slide, we start to see what has been the increase or driving the increase in weekly compensation. And as you can see, over the last decade here, there's been a significant increase in a couple of the cohorts. The most obvious one there is soft tissue injuries, and you can see that's the top line and a dramatic increase over those 10 years, with now soft tissue injuries accounting for 2/3 of all weekly compensation. What's slightly more difficult to see, but is a significant increase, is the orange line there at the bottom of the graph, which is concussion, which, although small in volume, has been increasing at a rate of 15% year on year over this period. If we think about that increase in weekly compensation, what that translates to, compared to 10 years ago, if we had the same rates now as back then, we would be spending $500 to $600 million less on weekly compensation. It's a significant amount, making it, as you will be aware, a really big impact on the scheme's sustainability. Go to the next slide, we'll see that the point here is that, beyond the costs and the money, actually are patients, whānau, and the wider society. And the delayed recovery has a significant impact on not only individuals, but their broader social systems. While we understand, and you'll be really aware that there are a range of factors which influence recovery rates and lead to that determine whether a person ends up in a prolonged recovery and on weekly compensation, what we do know is that long-term worklessness, as it's termed, has been associated with higher rates of significant physical and psychosocial poor health. It's also really significant impact on whānau, on relationships and employers and the wider society. And they're all part of the reason why we really need to focus on how we can support better outcomes to recovery. Finally, and I think this is another key point, is that there's clear evidence that the longer a person is away from work, the less likely that they will ever return to work and the more likely they are to lose their job. So compared to 10 years ago, when only just under 5%, so around 4.5% of people were on weekly compensation for more than 365 days, so for 4 more a year, that is now double. So people on weekly compensation, 9% now have been on for more than a year. I'm going to hand back to Stafford.
Hey, thanks, Peter. Hey, we're just at the start. This is a brainstorming exercise, and we want to hear your ideas. And to be clear, this is the most important part of the process, is understanding what you can do and how you think you can contribute to this opportunity. Specifically, we've got 2 opportunities to really move this forward. The first of this is to get your ideas, and we're looking for any idea that could improve rehabilitation outcomes and how we collectively, ACC with primary care, work more effectively. We'll be asking you to submit your ideas via a simple application form, and the form will ask you for your ideas and the impact that they could have. You can also indicate if you or your organisation wishes to work with us to help develop and progress that solution. We're not looking for fully costed proposals or solutions that require legislative change. Legislative change can take considerable time, resource, and requires a different approach. What we're looking to do is understand what we can do to improve rehabilitation outcomes and how we can better work with primary care within our current and existing legislative boundaries, so that we can help drive improvement in our rehabilitation rates and help New Zealanders return to independence. We want to hear from you about how you think you can work differently with us and the positive impact that will have on patient outcomes. We will send an email to everyone who has registered for this and have an access on website so that people can access information about how to submit ideas, and further detail will be placed in that, and Cody will talk about this in more detail, the practical applications, shortly. Through the process, we will have a Q&A function, so when people submit ideas, so that all questions will be visible, but also so that all answers can be provided to everyone so that you can see the good ideas that are being generated and to help form potentially your own responses or your own suggestions that you might have to ACC. You'll have around 3 weeks to submit ideas, with submissions closing on the 16th of March. Next slide, thank you. The second opportunity. The second opportunity is about ACC forming an external reference group with a specific focus around primary care. We're looking for a range of clinicians and leaders in the primary care sector to form a primary care advisory group to provide ACC guidance on potential solutions that will have a positive impact on recovery outcomes and how we can work with the primary care sector. To express your interest in being part of the group, you'll need to complete a simple EOI application form, which again we will email to everyone who has registered for this event. You can nominate yourself or somebody else. We will ask you to talk about your background and the experience that you bring that is relevant to this initiative and how you believe you can help address this challenge with our organisation. We will be sending, as I said, this link to everyone who has attended this session or has registered for the session. We expect the reference group to be established by April and a meeting on a regular cadence from that point forward through 2025. I'm now going to hand over to my colleague Cody Bedford, who will just walk us through exactly how people can get into the various forms and application processes. So thank you, Cody.
Thanks, Stafford. Look, we really want your ideas and we want to make it as easy as possible for you to get your ideas to us. We are using GETS, which is the online system that government organisations generally use to promote opportunities to work with us. If you do want to submit an idea or expression of interest, you will need to register to use the GETS system first. Once you've logged in, search for ACC, look for Working Together to Improve Outcomes, General Practice, subscribe to the notice to download the forms. We ask that you do use the Q&A function as Steph had mentioned to ask any questions and do review the previously answered queries. If you have any issues or you need help using GETS, there is a supplier help link on the homepage. As you'll see on screen, there's a bit of an indicative time frame if you need to refer back to it once we do share the slides with you. Once submissions have closed, we'll spend some time reviewing the ideas, which might take some time. Around April, we'll update you on the next steps and any confirmed outcomes. This is likely to be via provider update and possibly another online engagement like this one. If it is an online engagement, we'll let you know in advance. On screen are some of the other ways you can stay connected to this work and other work we might have on the go. We have a dedicated webpage on acc.co.nz that holds all the information on these health sector engagements. This page is called Working Together to Improve Patient Outcomes and sits under Provider News and Events section. This will include the GETS details shortly for the forms. Our monthly provider update newsletter will also be a good source of information. We'll provide regular updates through this, so if you're not already receiving it, please go to our website and search for Provider Update and click on the subscription link. Now I'll hand back to Chris for some questions and answers. Thanks, Chris.
Cody, thank you. And we've probably reached the point, just over 20 minutes in, where you've probably heard enough from us for a little while. And so now we probably need to move to some of the questions that have been submitted and hear what you have to say. So we've themed those up, and we'll start with the questions that were kindly submitted in advance of the event. I'll hand over to my colleague Lee Aston, who's going to act as question master and fire those at the members of the ACC panel. Kia ora, Lee.
Thanks, Chris. So the first question I'll hand over to Marion to answer. So in the registration process, we did have a very strong theme coming through from GPs who are certifying patients as fit for selected work, but they often feel pressure from their employers, from their patients' employers and the patients themselves to change the medical certificate to fully unfit for work instead. So what can ACC do to change this behaviour and support GPs and nurse practitioners who are certifying for work?
Thanks, Lee. That's a great question. I can honestly say that we've heard this come up quite a lot, and we've had some really awesome GPs and nurse practitioners via some of the conferences that we've been at that have come and spoken to us about this. So one of the things that we've done in order to try and support this issue is we've developed a resource alongside general practitioners that they can give to patients. This resource explains fit for selected work certificates and the benefits of this type of certification. It also really goes into kind of the detail and the benefits, and it's a really awesome handout that you can give to your patients during some of those kind of more difficult conversations. The other thing that we have is we do have a dedicated team within ACC that works directly with employers. I can confirm that they're working really closely with employers to educate them also on the benefits of recovery at work. We also have resources that we've developed alongside general practitioners and employers that are available on our website to kind of help those kind of conversations. That team has a pure focus this year also on helping people recover at work. So that message is being kind of loud and clear. It does take an absolute team effort to be able to get this journey off right. And so I just wanted to say that yes, there might still be work to do, but we're actively working with employers at the moment. Thank you, Lee.
Great, thanks for that, Marion. So the next question I'll pass over to Stafford. So is ACC considering how GPs might be better able to work with other rehab providers or treatment providers who are supporting their patients? So for example, vocational rehab services.
Yeah, thank you, Lee. It's a really good question. I mean, one of the things we're very conscious of is the health system, the fragmentation of the health system, and it's not easy often for health providers to navigate across the health system and engage with the various people who are required to support someone's rehabilitation and treatment. And in particular, I think ACC has to acknowledge we are part of that, and we've been an organisation that's often hard to engage with, hard to get referrals through or get understanding of next steps in someone's rehabilitation journey. and often have created environments where it's unnecessarily siloed. So it makes it hard for you as a clinician when you're supporting your patient to recover or return to work to get all the supports that you need. So on that basis, yes, we're very open to looking at opportunities for vocational rehabilitation or other services that someone might require from a primary care setting to be easier for primary care to get access to. So open to a range of suggestions in that context, because we believe there's a real opportunity to increase the integration between primary care and the rehabilitation sector for better outcomes and make it easier for you as clinicians to provide the care that your patients need.
Thanks, Stafford. Now, Pete, I'll ask the next question of you. So can you just let us know, with the solutions or ideas that ACC is looking for, are we looking to have a consistent national approach, or will it vary between the regions?
Yeah, thanks, Lee. So look, firstly, the thing we're really after is being consistent in improving outcomes. We are really focused on what we can do differently to improve outcomes for patients who are being seen in primary care with injuries. So look, that's the first thing. I sort of think that if there was a single big bang solution that would solve the problem for everybody across the country, we'd know that, but maybe we don't. And so if somebody's got that, we'd love to hear it, because that would make our job really, I guess, a lot easier in some ways. We suspect that there will be a whole range of solutions proposed, that they will be different and nuanced to the communities they serve and the situations in which you are delivering care. So, look, we fully expect there to be a range. We fully expect there to be difference across the regions. We imagine there'll be common themes and threads that go through that. But look, no, we are not looking for just one type of solution, but ones that fit and are appropriate to those communities they're serving.
Thanks, Pete. Another question for you, Pete. So will ACC be considering ideas for potentially new pathways of care for primary care? So, for example, management of lower back pain.
Well, look, as I think everybody is aware that variation in clinical care is one of the big drivers of quality. And so clinical care pathways have a role in that. They're not the only thing. And we have done, a range of work on that area. So there's always opportunities for doing more clinical pathways. That's not the focus of this, but we're really open to suggestions around that. And if there is a real drive to do that and there's some momentum around that, that we'd be really happy to look at doing some new and working with you about developing some new clinical care pathways.
Thanks, Pete. Next question I'll pass over to Marion. So will ACC consider ideas that might need some technology change, for example, updating the ACC in 18 and ACC 45 forms to make them easier to use?
Thanks, Lee. That's another great question. Over the last few years, we have definitely heard loud and clear that the current ACC 45 and ACC 18s can make it really hard for you guys to be able to do the right thing. We have definitely heard that loud and clear, and so we are open to any ideas and solutions around that you may have. We also have heard loud and clear regarding clinical notes, and we have kind of set up the solution or the contract with ConnectNet to ensure that online transfer of medical notes, and we know that 98% of general practice teams utilise that service, and we get really, really good feedback around it. So there are tech solutions that are out there that we could be thinking about, being able to communicate much better. I see there's another kind of question in the chat around, it's so painful to be able to get in contact with us and you're waiting on the phone and you just don't have time for that. We're asking you questions, sending it via email, versus if we could just have one place that we all can connect, it would make things so much smoother for everybody. So I guess what we're trying to say is, if you have ideas, please put them forward, because we really do want to make a difference to make things easier for you to do the right thing. Thanks, Lee.
Thanks, Marion. Next question I'll pass over to Stafford. So you've acknowledged that ACC historically hasn't invested enough in primary care. Does that mean there will be additional funding for general practice?
Yeah, a good question and a very fair question. look, and as Chris has indicated, we believe there is a mandate to look at increasing funding and significantly looking at our investment within primary care. There clearly, historically, we have not, or recently have not funded primary care in the same way aligns with the importance of primary care within the health sector, and it clearly is an important part of the health sector for ACC. We do need to make sure, though, also we align this funding with initiatives and improvements that will improve access to the right services for our patients and clients and deliver better outcomes regarding helping New Zealanders return to independence and return to work.
Lee, you're on mute.
Thanks for that. Thanks for that, Stafford. Staying with you, Stafford, could you give us an idea of what you see as the key areas that ACC would like to see improvement against, for example, earnings-related compensation or other areas of spend, and what timelines are you working toward to have these solutions in place?
Okay, look, that's a really good question again, Lee, so thank you for who asked that. So firstly, I'd say you've heard a couple of comments we've made today, and I just want to reference back to them. So firstly, we've talked about in the last 10 years, the likelihood that you have ended up, starting weekly compensation as an employed New Zealander has increased by 30%. So we don't understand why that is, but you're 30% more likely to start weekly compensation today than you were 10 years ago. We also know that we have twice as many people on our scheme who have been on our scheme for longer than a year than there was 10 years ago. And more than half of those people have what we describe as relatively mild or moderate injuries, so injuries that don't explain ongoing incapacity. And the other point I'll just make in that context is if our current performance regarding the rates people were entering weekly compensation and the length of time that they spent on weekly compensation aligned to our performance in 2014 as an organisation, we would be spending more than $500 million less a year on weekly compensation than we are today. So clearly for us, there is a clear mandate and a direction to look at solutions that can help New Zealanders recover, return to independence, but ultimately return to work. And we are open to opportunities to invest in primary care and partner with primary care to achieve that outcome. In regards to the timeframe, we are looking to move forward quickly. We're open to a range of ideas. We will be interested in ideas that can be executed in the short term, medium term, and long term. So we are interested in a range of opportunities to help move that forward.
Thanks, Stafford. So I'll just open this question up to the floor to the rest of the presenters, whoever wants to jump in and answer this one. So this one, because rehab and return to work is a team-based issue, sometimes it will be easier to discuss patients as a team to ensure that the patient is getting consistent messaging and a plan. So how can this be organised and funded? And it would stop playing one therapist against another and give more consistency of care.
Marion, is that something you would like to address?
Certainly. Thank you, Chris and Lee. So in a future world, we absolutely would have kind of the mechanisms and the way to kind of enable this and make sure that it is a really easy thing to do. I can tell you that right now, there is a code that is available if you're needing to have a multidisciplinary let's say case conference regarding a patient, where you need to get the patient, the employer, the return to work provider and yourselves in a room. There is actually a code that you can use right now to pay for your time to be a part of that case conference. As part of the Q&A, we will make sure that we do share that with you, but that's it for now. In the future, we would absolutely, again, welcome any ideas of how you think that we could do that better.
Great, thanks, Marion. So, Peter, I might ask you to answer this one. So, there's been a lot of interest in the questions around the data that we've shared today. And so, one of the questions was, has ACC accounted for things like population increases, increasing age, weight, and burden of chronic disease in the population, and what we're seeing with people taking longer to recover? And similarly, as people are retiring later due to cost of living pressures, etc., is this older workforce contributing to these statistics?
So, thanks, Lee. Yeah, look, we try to account for as many of those factors as possible in the calculations. Just so you're aware, ACC is full of people who are really good with numbers, and they spend an awful lot of time trying to understand the drivers of costs. So, that's an integral part of ACC. So, yes, we accept that there are some of those factors. Yes, we try to account for that as much as possible. I think we need to come back to that, yep, there may be a contribution of that to the increasing volumes. And so we're conscious of that, but we're also aware of the overall significant uplift, which are really starting to impact on sustainability of the scheme. ACC, is something that I think New Zealand has been really, really fortunate, and we all feel like this is part of what makes our health system one of the better health systems in the world, that we've got this scheme in place. What we're needing to do now is, I think, is to learn from the past but build a better future, which for us starts with primary care and how we can share in developing a way of working with primary care together to actually ensure that we're getting better outcomes for those populations of patients you're serving.
Great, thanks, Pete. Next question I'll pass over to Marion. So GPs aren't specialised in occupational health or occupational medicine, so how can they be expected to know when the patient is ready to get back to work?
Great question. And it's actually something that we've also heard over the last few years. And that's one of the reasons why we really took a deep dive into our medical certification definitions, making sure that they were really, really easy to understand. And we also really wanted to make sure that general practitioners and nurse practitioners, you understand that you do not have to have a degree in occupational medicine. What we are asking you to do, because you know your patients best, is based on their injury presentation. What do you think that they are safely able to do? That's really important, what they can do versus just not what they can't. And then also advising of the restrictions. That's all we are asking you to do. From there, ACC can either liaise with the employer, so the case manager can liaise with the employer to see if there's anything that would match, or if it's a bit more complicated than that, we can engage with a vocational rehab provider and they can sort that out on your behalf. So I just want to really kind of reiterate that point. We do not expect a general practitioner or nurse practitioner to understand every single New Zealander's job duties. That is absolutely just, it's impossible. We do acknowledge that, again, that communication between VOC providers, ACC and employer could be improved. And again, if you've got ideas of how we could streamline that, please do put them through. We've had a couple of comments in the chat regarding occupational health nurses that are working in workplaces. Again, if there's things that you are doing that are unique and are really getting good outcomes, please do put those as ideas through this process. We'd really be keen to hear what's working really well out there. So thanks for putting that stuff through.
Pete, was there any more you wanted to say on the back of that?
I just think it's really important to think that there are some things we can do now that, and we continue to focus on. Marion's talked about that, about how do we improve what we are doing now, because we're not going to be able to change everything overnight or next week or next month. But so we will continue to do that. So ideas that help us actually improve the immediate issues that you're facing are really helpful, but also please be aware that we're looking for transformational ideas here. We're looking for, if you were going to put out there how we could substantially change the way in which we do the business in terms of ACC and primary care, what are those ideas? And you're the best place to know that and to come forward with those. Now, No promises we can do that, but we need to be doing this together, and hence why we want your ideas, but also we want that reference group, that external reference group, to provide an ongoing conduit for testing out ideas and connecting with your expertise.
Thanks, Marion and Pete. So Stafford, there's a few people in the chat who are interested in being part of the reference group. What will the arrangements for payment be for being on that group?
Look, thank you. That's really good news, actually. So I'm pleased to hear people are keen to join our external reference group. It will be a productive and very useful group. So just to answer your question, we will be compensating people for their time. We won't be expecting people to travel, at least not initially. So we'll be doing everything via webinar or via online sessions. So to help with that, but we'll be compensating people for their time in the session, in addition to any preparation time that they will have. And so the details with that will be coming out as part of the email. But effectively, we'll be paying for 4 hours of time per meeting. And the meeting will expect to take probably about an hour and a half. So an hour and a half for the meeting and 2.5 hours of preparation time to get across emails and various other bits and pieces that might come through.
Thanks, Stafford. We've just had another question in the chat about whether we'll be sharing this presentation more widely. I can say that we will send out the slides and a link to the recording once that's ready to go out, so hopefully later this week. And do feel free to share that link with your colleagues who haven't been, if they haven't been able to attend today. We want it to get out as far and wide as we can. So Marion, there's been another question around particularly patients with either complex historical injuries or complex, diverse backgrounds, finding it really difficult to navigate ACC's systems and processes. And these types of patients can take up a lot of time and resources for both the GP practice and ACC staff as well. So what can be done about that?
That's another great question, and I've seen a couple of other things kind of come through with some patients obviously don't have access to the internet or feel uncomfortable even calling ACC. For those that don't know, we actually do have a free independent navigation service available that can offer advice and guidance about an ACC claim. So anyone that kind of needs additional kind of support, there is those navigators out there, and we're more than happy to supply the link with the questions and answers that we send out to everyone. We do acknowledge that sometimes it is hard to get in contact with us. Sometimes we're this big scary ACC and we're calling about, someone's calling about a claim and you're having to wait on the call and you hand it off to a whole bunch of different people. Obviously that's not ideal. One of the things that we have changed internally recently is our case management model. So for any patient or client that has their injury has impacted on their ability to work, we have moved away from where we were trialing out for a few years. We had the one-to-many kind of relationship to try and build some efficiencies within the system. We realized that probably wasn't really that great for some people. They really want to just talk to their person. So for especially for people whose injuries have affected their ability to work, they will now have a one-to-one dedicated case manager. So hopefully they can build that trust and respect, and also those case managers that are specifically working with that cohort of clients have also had additional training similar to what we're teaching or educating and going out there with general practice, to making sure that we're really consistent with our messaging and our expectations from all parties, because as we've kind of mentioned with our Recovery at Work campaign, it absolutely takes a team effort. It does not all fall on the provider, the client, the staff, or employers. So we really do need to work better together, especially for those complex injuries. Thanks, Lee.
Thanks, Marion. I just wanted to say we're starting to see some really good ideas coming through in the chat, and we do want to encourage you, no matter how big or small those ideas for improvement might be, that you do submit an idea through the process that we've talked you through today. It doesn't matter, you don't have to have a solution, but if you've got something that you think can be improved on, we really want to hear those. So just in the interest of time, we won't be able to get to all of the questions today, but we will definitely collate all those questions and provide written responses after this event. So I'll just hand back to Chris now.
Team, thank you. And thank you to everybody who stayed with us for the sort of whole 45 minutes we've been on the call. I'm aware this comes at the end of what's probably been a busy clinical day, and where we are hopefully now the last thing between you and your families and your dinners. But I think also, you know, second event of the day, and we've had good attendance and people staying on, I think is probably a really encouraging marker for us that this kaupapa is important, and we want to make it as easy as possible for you and the sector to engage with us and to work with you. So we really do appreciate your time. Thank you. I'll just wrap us up with karakia, and then, as the team have described, our conversation will continue with the follow-up information from the event and subsequent engagement. So ki enoi tātou. Whaia, whaia, whaia te tika, whaia te pono, whaia te aroha, mo te oranga tangata, kia puta ki te whaiao, ki te ao marama, haumi e, hui e, tā ki e. Good night, everyone.